give some remarks.
Hello, everyone. Thank you so much, Willard, and thank you, Dr. Funjika, for that welcome. We're so happy to partner with the Ophthalmic Society in Zambia. I think we've taken a leaf from you in your CMEs that we've been doing, and really we recognize the importance of having CMEs in terms of improving healthcare, as well as just interdisciplinary interactions. And the fact that we work together both in theater and outside of theater, I think having these sort of interactions will go a long way in terms of having evidence that helps us in making protocols, as well as having evidence really for the way we deal with our patients. So I'm so happy that we are having this interdisciplinary CME. And to Sampan Chalwe, I've seen the hard work that you've been putting in so far. And so we're looking forward to learning from both of you. And also a warm welcome to all the residents, both from ophthalmology as well as anesthesia, and everybody else who has joined in. And we're looking forward to a fruitful meeting together. So thank you so much, everybody. And we hand back to Willard to set the ball rolling.
Yeah, thank you very much for your comments. And without wasting much of the time, our journal club presentation is supposed to end at 18 hours. That's some 45 minutes from now. Okay, of note, I've just tried to see if I can record the presentation, and then I've made Dr. Chimozi and our presenters as co-hosts. Dr. Chimozi, are you with us? Dr. Chimozi Tembo?
Yes, I am.
Yes,
yes,
so just try to see if you're able to record. You can record to your computer and then retrieve it. I also try, but this is just for backup. So for anyone of us who miss out or anything, we try as much as possible to post this on our YouTube, on our YouTube channel, okay, so that you can access them. So I'll hand over to the two presenters, Dr. Sampa and Dr. Chale for now. So we'll straight away go into our presentations, and then you can take note of any points you want to make. They'll go on without being interrupted, and then at the end of which we are going to allow time for questions, for contributions. And like Dr. Funjika has mentioned, I think, and I didn't really think about it that way. I think we might need to come up with protocols that we can share in both in the private, in the public, and also in the periphery. It makes it much easier. So because of this, let me see someone from, let's see, Dr. Mebo from Ndola. I'll ask you to just take note of the notes or maybe some form of summaries that we might need to put in our presentation. And then Dr. Tembo also, yes, I'll also ask you to do the similar thing, okay? And then we can have someone from anesthesia, Dr. Mumpasha, can assist. Someone who can just take note of a few summaries or a few points that perhaps we can use to make our protocols that we can be using, or something that the people are coming can use for pediatric ophthalmic anesthesia.
Okay, I think I saw Dr. Imran. So I think Dr. Imran can do so.
Okay, thank you, Dr. Sampan. Dr. Chalwe, over to you.
Good afternoon, everyone. Welcome to today's journal club. And like Dr. Mumbi said, today's journal club is combined. So I'm presenting from Dola Teaching Hospital, and I have a co-presenter who's presenting from UTH and representing Anesthesia Society. Okay, so today we'll be looking at a journal from the European Journal of Ophthalmology, which was published in September 2018. It has an impact factor of 0.81 and it ranked number 22. The title is Prospective Evaluation of anesthetic protocols during pediatric ophthalmic surgery. So, like Dr. Funjika said, pediatric ophthalmology is a growing field, and this is a field that deals with eye conditions in children. And so the management of the eye conditions that children have has two streams of management, which can be surgical or medical. And under surgical, we have some of the indications that will require us to do surgery, which in our setting includes trauma, strabismus, cataracts, examination under anesthesia, and extraocular lesions. So most of these patients that require surgery will need to undergo general anesthesia, because children usually don't cooperate under local, so you have to take them to theater and do the procedures under general anesthesia. And today we will discuss some of these common complications that we encounter in these surgeries. So one of them is the trigeminal cardiac reflex, which is the brainstem reflex that results from stimulation of any of the branches of the trigeminal nerve and is characterized by reduction in heart rate and mean arterial blood pressure. So trigeminal cardiac reflex can be divided into central and peripheral. And peripheral is further divided into oculocardiac reflex, which is our area of interest, and also maxillomandibular cardiac reflex, which is usually encountered by our colleagues, the dental surgeons. So this is a picture just outlining the reflex itself. So it starts by manipulation or stimulation of ocular muscles, which can happen during surgery, or it can happen in entrapment, in trauma, which sends the afferent signals via the long ciliary nerve and into the ophthalmic branch of the trigeminal nerve, into the main sensory nucleus of the trigeminal, which is in the midbrain, which now directly connects to the motor nucleus of the vagus. It is through the vagus, which is the cranial nerve 10, where the efferent signals will be sent to the heart, and that would depress the activity of the heart, leading to reduced heart rate and reduced mean arterial pressure. Some of the manifestations of oculocardiac reflex will also include hypermotility of the GIT and also apnea in children. So oculocardiac reflex can occur in adults as well, but studies show that it is most common in children. So before we actually go into the summary of the article, I'll allow Dr. Charlie to just give us her introduction so that she can share with us what general anesthesia is, and also just highlight some of the other complications that I haven't mentioned. Dr. Charlie, over to you.
Okay, thank you very much. So for me, I'm just going to briefly also just give us just a small introduction into anesthesia, this being a multidisciplinary meeting. So our anesthesia is basically divided into two portions. We have general as well as regional anesthesia. So this picture here is basically depicting general anesthesia, in which it's anesthesia which is drug-induced, and it's a reversible condition that induces specific physiological changes to bring about unconsciousness, amnesia, analgesia, as well as akinesia. And then we also have regional anesthesia, in which a specific part of the body is anesthetized. So specifically with ophthalmology, the common blocks, regional blocks are Tadana peribulbar, subtenos blocks, as well as retrobulbar blocks, and use of topical anesthesia as well. So the anesthesia can be further subdivided into the different specialties, but of importance is pediatric anesthesia. Pediatric anesthesia is basically looking at the fact that children are not necessarily small adults, but they have their own anatomical and physical anatomical and physiological differences. So these are just a few of the categories in which we have these differences. So in anesthesia, one of the most important ones being airway and respiratory differences, also cardiovascular, and then these other systems which I've mentioned, which have been displayed here. So our main area of focus during one of the complications that we're going to particularly focus on, one of them being post-operative nausea and vomiting, abbreviated as PONV. So basically nausea, sensation of vomiting, expulsion of gastric contents. This usually occurring within the first 24 to 48 hours after surgery in inpatients. And then another term we'll be looking at is post-operative pain, basically an unpleasant emotional experience experienced by patients within the same time frame. So this pain, the pathways in both children and in adults are very similar. The only thing of note is it's acute with a rapid onset, and it gradually resolves in most of these patients, and it's usually prevented by multimodal modalities. So we will talk more about it as we go through the article. So for now, I will hand over back to my colleague, and we can begin looking at the article.
Okay, thank you so much, Dr. Chalwe. So today's article, like I mentioned, is from the European Journal of Ophthalmology. Okay, my screen is frozen. Okay, so the title is Prospective Evaluation of Anesthetic Protocol During Pediatric Ophthalmic Surgery. The aim of this study was to evaluate the complete anesthetic protocol for pediatric ophthalmic surgery that were employed at the hospital where the study was carried out. The study was a prospective, monocentric observational study, and it was carried out at University Hospital of Nanterre in France. And this study was done between the period of November 2015 to May 2016. So the kind of patients that were included in this study were all the patients that required pediatric surgery during the period of study, that is from November 2015 to May 2016, which were a total of 122. And the exclusion criteria that was used was missing data. So it was noted that 16 patients from the study had incomplete data and therefore were excluded from the criteria. So with what was done, the modalities that were evaluated and how the data was analyzed, I'll ask Dr. Chalwe to just share. Dr. Chalwe.
Thank you. So for the data analysis and collection, the hospital modality that was used is they had both ambulatory patients as well as inpatients. The number of operative procedures were done. There were quite a number of different procedures, but the main ones of interest to us are three main procedures, which was strabismus surgery, congenital cataracts, as well as botulinum injections. And then administered medications was the use of antiemetics, and as well as the use of paracetamol and opioids as analgesics. And then the post-op complications that we will focus on are the ones which we've already mentioned, the oculocardial reflex, PONV, as well as post-operative pain. So this is just showing us the anesthetic protocol that was used for these patients during this study. Patients were initially given midazolam just to sedate the patients, as well as at these dosages which have been indicated, given both parectal as well as sublingual. For gaseous induction of anesthesia, halothane was used, peripheral IVs were placed, and anesthesia was maintained using a propofol infusion. So this is what was done for all patients, as well as administration of paracetamol. The opioids that were used were sulfentanyl and profenib, which is just an NSAID. And then what was used for neuromuscular blockade was atracurium. And for prevention of post-op nausea and vomiting, the antiemetics, patients were either given dexamethasone combined with ondansetron or ondansetron alone. And then for analysis of the post-operative pain, three different scales were used to analyze to assess the level of pain the patients experienced afterwards. So we have the VAS scale, NPS, as well as the FLAC scale, whose results we'll look at when we discuss the results. And then for the data analysis, for the quantitative data, the student's t-test was employed, and then for proportions, the chi-square test or Fisher's exact test were used. Okay, so we will look at the next. I think we'll look at the results.
Okay, thank you, Dr. Charlie. So for the results, with the hospitalization modality that was considered, it was found that 90% of the patients that were operated on at this hospital were actually ambulant and didn't need to be hospitalized. And in the 10% that needed hospitalization, the reasons, there were 11 patients, and the reasons were because 6 of those patients were less than 1 year old, 3 patients stayed very far from the hospital, 1 patient had a cardiac history, and 1 patient was admitted because they had persistent postoperative nausea and vomiting. So for the surgical indications, most of the patients, like 50% of the patients came for strabismus surgery. And then a quarter of the patients came for examination under general anesthesia. And the other quarter included procedures such as trabeculectomy, vitrectomy, congenital cataract extraction, keratoplasty, botulinum toxin, to mention but a few. So when they further analyzed the complications that arose from the general anesthesia and the surgery is done, one of the complications that they analyzed was oculocardiac reflex. So in this diagram, we have the diagram showing the incidence of oculocardiac reflex and also what kind of surgical intervention was actually done. So from the diagram, we can see that for patients that were undergoing strabismus, there was an incidence of oculocardiac reflex of about 65%, followed by patients that had cataract surgery, and the incidence was about 50%. Then in botulinum toxin, we had 33%, about 33% incidence of oculocardiac reflex. And then in the other procedures such as examination under general anesthesia and others such as trabeculectomy, no incidence of oculocardiac reflex was recorded. The other diagram on my left actually shows a relationship between the oculocardiac reflex incidence and other surgical parameters that were being analyzed, such as what type of surgeon was working on the patient, the indication for the procedure, what type of squint that the patient had, and which specific squint correction method was used. And from the diagram, we can actually see that there's no significant relationship between these surgical parameters and the incidence of oculocardiac reflex. So, for example, between Surgeon 1, Surgeon 2, and Surgeon 3, the oculocardiac reflex incidence, there's not much difference. So those parameters had no significant effect on the incidence of oculocardiac reflex. And then for postoperative nausea and vomiting, it was noted that only 5 patients out of the 106 developed this complication. 1 patient developed the severe form during the recovery room. And then before the first hour, we had 1 patient who developed the moderate form. After the first hour, we had 2 patients that developed the moderate form. And after After 2 hours of being observed, again, we had 2 patients that had a moderate form of postoperative nausea and vomiting. But in general, the diagram actually shows that most patients did not develop post-operative nausea and vomiting. So Dr. Chalo will share the rest of the results. Dr. Chalo, over to you.
Okay, thank you. So this was another, this table here was another representation of the same findings, which my colleague has alluded to. So as she mentioned, only 5 patients were noted to experience post-operative nausea and vomiting. And then as this table shows us, the discrepancy in these patients was very minimal in those
Excuse
that
me, Dr.
received
Chalo,
opioid.
could you,
Your
yes,
screen,
excuse
we
me?
can't see your screen.
Yes, could you just share the screen?
Oh, it's not visible. Oh, sorry. Is it visible now?
Yes.
Okay, great. So what I was saying is in the 5 patients that experienced post-operative nausea and vomiting, there were very few discrepancies in between 2 groups that were divided. For instance, patients that received opioids in the recovery room and those that didn't, patients with retroequatorial myopexy and those without, and then patients with post-operative pain and those without it. So there wasn't much difference between the 2 groups. The only group in which there was a notable difference is of those that received preventive antiemetic drugs. One was given just dexamethasone, another was given dexamethasone combined with ondansetron. So this pie chart here is also showing which of the surgeries that were done, which particular surgeries elicited these complications. So this larger part were those that were undergoing strabismus surgery, followed by cataract surgery, examination anesthesia, lacrimal duct sounding, as well as vitrectomy. And then regarding post-operative pain, this is basically showing us at time 0 and at 1 hour and at 2 hours, the activity levels in which the patients, what the patients had displayed. So majority of patients at 2 hours, or only 1 patient showed reduced activity, and that's the patient that was later on hospitalized overnight. Okay, so I'll hand back over to my colleague, so we'll discuss the author's interpretation.
Okay, thank you, Doc. So the interpretation of the authors was that with regarding oculocardiac reflex, they got an incidence of 65%, which was in keeping with the literature review. So according to literature, the incidence of oculocardiac reflex in ophthalmic surgeries is between 50 to 100%. And so it was actually concluded that this incidence can be reduced by preventive drugs such as atropine, or by switching what kind of drugs we use to maintain anesthesia. So it was noted that drugs like propofol actually had a higher incidence of oculocardiac reflex compared to halogenated agents like halothane. And then it was also noted that patients who developed this complication of oculocardiac reflex stayed longer in theater than those that did not. And so preventing this complication was actually cost effective because it cut down on OT time, which was cheaper for the patient. And then for local and regional anesthesia, there was no local or regional anesthesia that was used in this study. And there are lots of conflicting studies concerning this. Some studies show that the use of local anesthesia on top of the general anesthesia that you're actually giving to the patient may reduce these complications. And then there are also other studies that say there's not much difference between those patients who be given opioids and things like paracetamol and those that will be given topical anesthesia. So the debate is still on and more studies need to be done. but the authors interpreted that maybe if they had actually given local anesthesia to their patients, maybe it could have reduced postoperative pain and also reduced opioid administration with a reasonable cost. So before we go into the critiquing of the journal, I'll allow Dr. Chalwe to also give the other interpretation of the author. Dr. Chalwe.
Thank you. So again, with regard to post-operative nausea and vomiting, the incidence was seen in 9.6% of patients following strabismus surgery, and then 0% in other patients. And then, as my colleague had mentioned earlier, the post-operative nausea and vomiting had resolved within 1 hour of the operation, and this was after receiving antiemetics. And then it persisted in one patient. This is in comparison with what literature tells us, that without an antiemetic, in patients undergoing such a surgery, there's an incidence of between 65 and 90% that these patients will experience this complication. So this is according to other studies that have been done, other figures that we looked at. So which is basically corroborating that a multimodal approach is necessary to prevent this complication. However, from literature and from what the author of this article had concluded, what was also said was that dual therapy of antiemetics is not necessarily superior to monotherapy. So a single drug can possibly be employed rather than combining, as what was done here. Thank you. So basically, in conclusion, what was found was that low morbidity was associated with, was attributed to general anesthesia, and the complications were primarily associated with strabismus surgery rather than the other procedures. And then, as what we earlier alluded to, further evaluation is definitely required to help prevent complications, in particular oculocardia reflex and oculocardiac reflex. And post-operative nausea and vomiting incidence was noted to be relatively low. And yeah, so basically, as we said, more studies are needed to try and develop the best approach to either prevent or treat these complications. Okay. So for now, we're going to go and begin our critique of this paper. I don't know if we can proceed or if we have any questions at this point.
We proceed. You reserve the questions at the end of the presentation. You can proceed uninterrupted.
Okay, thank you. So this is our personal critique of this article. So regarding the study design and the study period, we felt that the time frame that was given, that was from November 2015 to about, it should be May 2016. We felt the time frame was adequate enough to get an appropriate sample size to carry out this research. But one issue we had was that all patients were enrolled. Certain factors were not taken into account, such as comorbidities. So we felt that might have also, had we known certain comorbidities the patients had, that might have also affected our pattern of results as well. So that's for those were just some of the basic thoughts we had on that point. Okay. And then
Okay.
Dr. Campbell.
Okay, then for the assessment, we believe that our critique is that the variables that were actually looked at especially the complications, were actually adequate to answer the study question. So they actually properly outlines the protocol that was used, and also looked at the major complications that we could encounter, such as cardiac reflex, the postoperative pain, and also the postoperative nausea and vomiting. So those three were, I think they were good measurements to have to answer the study question. Then for the results, Dr. Shelley, just move to the results for me.
Sorry.
Yes, then for the results, yes, the results show very low incidences of the complications, except for oculocardiac reflex, except that the results, we don't have much to compare to, since not much studies have been done with regards to anesthesia that is used in pediatric ophthalmic surgeries. And then we also have a bit of a problem with the results because the confounding factors were not really addressed. So we don't know any of the patients, except one patient was mentioned to have had a cardiac history, but we don't know the other conditions or comorbidities that the other patients may have had. And also the time that they observed the patients. They only observed the patients for 2 hours after the surgery. And yet we understand that postoperative pain or postoperative nausea and vomiting can actually occur within the first 24 hours to 48 hours. So we feel that the time of assessment was not enough to actually come up with the results that are precise and accurate. Then for interpretation, yes, so even the interpretation of the results, yes, they've told us the morbidity is very low and it's associated with strabismus. Yes, that is in keeping with literature, but the fact that we had those problems with the results, and also the fact that the authors themselves keep encouraging us to further evaluate means that we have to look at the results of this study with a pinch of salt and actually be encouraged to do our own protocol evaluation so that we can come up with something that works for our environment. I'll allow Dr. Charlie to give the extrapolation of the study.
Okay, so just extrapolating, basically, just echoing what she has just mentioned, that this particular study, can possibly be extrapolated to our setting in order for us to come up with our own protocols and modify them accordingly. In order to prevent the three main complications that we have mentioned. And these protocols also enable the two departments to work together. It encourages collaboration between the two specialties. And then it also helps inform, like from an anesthetist point of view, it also helps, I would say, it also helps us reveal to surgeons that there are these complications that are possible even in the post-op period and at a time when they're no longer with the patient. So these are things that ophthalmologists and other surgeons can also bear in mind as they are also treating these patients. So this is something that is very practical that we can possibly do and work on. So thank you. That's basically what we had to share with you today.
Okay, a great thank you to both the presenters. It was really an amazing way on how you worked together as a team, and you could see the fluidity that was there. So, you know, when you work together, everything is possible. So we hope to see such collaboration even in terms of patient management, because at the end of the day, it is the patient who is at the receiving end. And then also the fact that the two presenters actually doing this presentation for the first time, they really put in a lot, and the quality of the quality of presentation is really amazing. Thank you both for the amazing presentations. Yeah.
Thank you, Dr. Mumbi.
Yes.
Thank you.
Yes, so before I open the floor for discussion, just want to mention that we chose this particular article. The motivation was we are trying to find a way of avoiding individual specialties working in isolation. As you may know, when you're managing a patient, the patient is one entity. The patient is not an eye. The patient is not the brain separately. The patient is not the heart. Okay, so most of these patients that we see, they cut across different subspecialties. So the more we encourage such interactions, the more we improve the quality of care. For us in pediatric ophthalmology, we can't do without anesthesia. It's practically impossible. You can't have a practice because just even simple things like refraction that will be required to be done, you need an anesthesiologist. You can't just do it alone. So for us, among the specialties that are prime of much importance is the anesthesiologist. And then the other reason is trying to see how, again, we can collaborate, work together, like Dr. Funjika had mentioned, or now at times we can come together and form protocols that can guide the practice pattern. Because we realize that most of the things that are done are not evidence-based. So whoever person is, for example, in Solwezi alone or is in Kasama alone, who have no guidance, you know, and if you have such a patient, they don't know what to anticipate, simply because, not that they don't know, but because they don't work mostly with pediatric ophthalmic patients. So they should be able to know what things that they should anticipate. And also, sometimes we think that just because we are doing a simple procedure on a child, we're just doing EUA, or we're just maybe cutting the muscle, just maybe suturing the cornea, that it is safer for the patient. But we must bear in mind that all these have risks, okay? And by the way, all these things, in most of the instances, we should be able to explain. When you're getting the consent, we might need to modify the way we do the consent, because if it gets sued, the patient has a right to know most of the major complications. So you need to tell the parents, not just mentioning that the risks that the patient is likely to have with death. You might need to explain a bit in details and maybe write a few lines so that this can cover you even when you are faced with a lawsuit. So as I open the floor, I don't know whether Dr. Mupasha at this point has something to say on the reason for choosing the article.
Yeah, thanks so much, Willard. I think you've said it. You've said it all. We chose this topic because we realize, as everybody has been mentioning, that pediatric ophthalmology, as well as pediatric anesthesia, these are emerging fields in our situations. And you know, sometimes there's a notion that some of the cases in pediatric ophthalmology are small and short, and so therefore may not have like serious complications. But I think one of the things that this paper highlighted is that you can have quite significant complications, and that having protocols is very important. But I think there are people probably on this forum who are doing a lot of pediatric ophthalmic anesthesia, and I would love to hear from them as well in terms of what protocols they've been using in their own scenarios, in their own hospitals, as well as hear from the ophthalmologists what steps they are also taking in mitigating some of the effects of ophthalmic surgery on oculocardiac reflex.
Yes, so at this point, perhaps I just taken note, like to welcome Dr. Paula Smith from Kitwe, Dr. Mtati from UTH, the SMS for UTH, Dr. Tuso again from Botswana, Dr. Malemane is from Blaoyo, is a pediatric ophthalmologist who awaits to help us also on your experience from that side. Dr. Ushma, as the anesthesiologist, and Dr. Christine, and all other people have just joined us that I may not mention. Dr. Chupaila, coming interestingly from a different field in surgery. You might also help us at the end to give us your perspective or your experience. So at this particular point, I'll open the floor for discussion, both for the critique of the article and also generally a comment on the pediatric anesthesia in general, since we're also having colleagues from other fields. So anyone who has a comment, you can either type in here. If unable to hear you, you can raise your hand, or you can just simply jump in and talk. We still have a bit of time. Interestingly, the presenters did a superb work. They summarized to the point, so it was short and sweet. Yeah, so as people are coming in, through my short experience, I think for me, I've noticed, from what I noticed also from the article, is that they mentioned the number of muscles, especially for strabismus surgery, that usually that they documented usually that do surgeries and experience oculocardial reflex. But one of the things that during training or or otherwise that they always point out, even during enucleation, is that every time you touch the medial rectus, you notice that the patient will have bradycardia. So one of the things that when you reach that stage of the medial rectus, you inform the anesthetist that you are doing, you have started touching the muscles. And every time when there's bradycardia, we'll either stop, release the muscle, or the anesthetist will decide to give atropine. Dr. Malemane, I don't know, what is your experience so far from your practice? Dr. Malemane?
I've also experienced a similar picture. When you handle the medial rectus, I mean, even for the squints, you do get a few changes on your ECG tracing. So, but what I've tried to do is to maybe give a bit of thing, subtenons prior to any surgery, and then proceed from there.
Okay, and yeah, it's quite interesting that you have given, you mentioned giving further anesthesia. I noticed some of the anesthesiologists during my training, like apart from giving a general anesthesia, you go ahead and give a block for the patient. I mean, you give perivalvular block. And Dr. Nchimunya, I think I'll reserve Dr. Nchimunya to come and summarize for us, but he always mentions that we give even topical anesthesia when handling these patients. And previously, when I had surgery with Dr. Mumpasha last time, she emphasized the importance of adequate analgesia in patients, actually emphasizing that we have to give even IV paracetamol. And one of the reasons, I think maybe Hazel, you might need to come in concerning what you mentioned about post-operative effects like bedwetting and psychological effects, regression of milestones on pain management.
Am I allowed to jump in?
Yes, yes, please.
Am I allowed?
Yes, yes.
Yes. I think from my experience, I think the other thing to do is that look at the protocols in two ways. Of course, there's a protocol that you'd want to come up with, which would be specifically for the treatment of oculocardiac reflexes, in case you have one. Then the other aspect of this is looking at what guidelines to put in place to help reduce the occurrence of the oculocardiac reflexes. So of course, with the oculocardiac reflexes, if you have, in my experience, when you have an oculocardiac reflex, you actually ask the surgeon to reduce the traction. Depending on what percent oxygen you're on, you can increase it to 100% oxygen. And then the other thing also, which the article also brings out, is the definitions. So according to the article, there are two definitions. One is when you have your heart rate, which goes below 60. And then secondly, another one, which I think came out through the article, which is very helpful, is also looking at your heart rate coming down by 20%. So those are the kind of things that you'd also want to put into your guidelines. And then on the aspect of prevention, are the things like the blocks, which from the article they actually said if you put either a retrovalvular or a perivalvular block, you can reduce the incidence by 5 to 10%. Then for subtenon blocks, they were not very sure on what the data is like. And then yeah, and then the other thing which I also liked in the article is the fact that they brought in the costing of theater time. It's very important to always look at the costing of theater time because it helps you plan. Then thirdly was also the aspect of whether you use for maintenance of anesthesia, whether you're going to use propofol, which is IV, to the inhalation, where there was much less incidence with the inhalational drugs as compared to the IV ones. I personally usually use the inhalation ones. And from my experience, I've only had like one. I've been in ophthalmic anesthesia for a year, and I've only sort of had one case, which I actually went to the point of giving atropine. For most of the oculocardiac reflexes I have, it's enough to just reduce the traction and then adjust your inhalational drugs a little bit, because usually it comes as a result of a lighter phase of anesthesia. I think that's all I had to share for now. I think my other colleagues can put.
Okay. Yes. Yes. So please, you can just come in if you have any comments you'll have to make.
I think I can make a comment in addition to Dr. Nchimunia's comment about using propofol infusion versus volatiles. I think it even reduces the incidence of post-operative nausea and vomiting when you use an infusion of propofol versus an inhalational agent.
Thank you, Dr. Ahmed. Any contributions? Yes, I know for some of the majority of the registrars, they do most of the cases they do Biconia repair and kids, and most of these will be under GA. Any of the challenges that you feel you face, just a bit away from the article. If there's anything that concerns the article critique, please you can come in. Yeah, can we have any comment from any of the registrars who are doing these GA cases every day? Dr. Serenge.
Hello, good evening.
Good evening, Dr. Serenge.
Sorry, this is Dr. Moka.
Yes, Dr. Moka, please go ahead.
Yes, Doc, I had a question. I think I've seen about 1 or 2 cases post-strabismus surgery that had PON V 6 hours after surgery, more than 6 hours anyway. So what I wanted to ask the anesthesiologist is, what can we give in that case? Do we just observe, assess and observe, or we can still go ahead and give the dexamethasone or dansetron? Thank you.
Dr. Nchimunya, would you want to come in? Dr. Mubasha?
Okay, I can come in. I think it's usually important, I think, to give ondansetron or dexamethasone or both. I think studies are quite variable on whether to give one or to give both, but I think it would be good to have given it prior to I think it would be good to know whether it was given prior to the post-op period or it wasn't given at all during the surgery, because I think this reduces the risk of post-op nausea and vomiting. So if you have this post-op nausea and vomiting, then I think you could still give it intravenously. You give your dexamethasone and ondansetron post-op if the patient is vomiting, as well as just other supportive treatments. However, Dr. Sylvie, maybe one of the things which I would like to ask, and which is one of the things that I wanted to ask about this paper, is that they give us a case of 5 patients who develop post-op nausea and vomiting. However, they don't describe much about the patients. I think I would have loved to hear more about the age of these patients, because post-op nausea and vomiting is by far very unlikely to happen in children who are less than 3 years old. But those that are above 3 years old normally have like an incidence of about 40% post-op nausea and vomiting, and will be required to given these antiemetics. So maybe it would be nice to hear if your patient was above 3 years old. So therefore that patient should have received antiemetics during the surgery, and can be given even post-op if they have a high risk. And also to hear from the two presenters and anybody else what the patient profile was for those 5 patients who actually had post-op nausea and vomiting. Thanks.
Yes, yeah. So Dr. Sylvia, could you just respond to that? And then we have Dr. Sampa and Dr. Chalwe.
Okay, thank you, doctor. Both patients were above the age of 3. I think one of the girls was about 9. As for the protocols that was used, I'm sorry, I can't remember the details. I just remember that the children developed vomiting much later in the night.
Okay.
Thank you.
All right. Thank you.
I just wanted to add, in this study, the mean patient age was 4.4. Out of a total of, there were a total of 122 patients. So regarding, hello?
Yeah, please proceed.
Okay, yes. So regarding the ages of the patients that experienced these complications, that wasn't specified, unfortunately.
Okay, thank you.
Only aware of, yeah.
Yes. Any comments from anyone? Dr. Ziambo, from either from the article in terms of critiquing it, or any from your experience that people can take away in their practice? Masuzio?
Thank you very much, Dr. Mumbi. I don't do a lot of ophthalmic cases in children, and I've never really fortunately, I've never had an ocular, but I know about the reflex. But I think what's important to take away here is, what do you do in a case where a patient has an ocular cardiac reflex? I think for the anesthetist, it's very important that we communicate with the surgeons and we proper oxygenation of the patient, and making sure that you know the threshold at which you're going to give him atropine. So like Dr. Chimunya has said, that he's had one patient where he's had to give atropine. I think it will happen, but you just have to be aware at what level of heart rate you're going to start thinking of.
Yeah, thank you very much, Dr. Ziambo. One of the things I noticed from the articles is just something away from anesthesia, is the way they were classifying strabismus surgery. So generally, I think I've noticed in most of the centers, they'll just group them as strabismus surgery, and then they'll say minor and major. So there isn't anything like minor and major. And that, I think the preferred way is the number of muscles, and that's what they did in this article. You will notice that they have grouped them differently. So it's about the number of muscles. If there is it 2 rectus muscles, I mean horizontal muscles, is it the obliques, things like that. And then yes, and then the other thing that I also noticed is either for anesthesia, the way that they were admitting for all the patients that were below the age of 1. These patients will be admitted. I'm not sure whether I really understood what this meant. So what is our practice, Dr. Nchimunya? Would you recommend that these patients below this age, even if it's EUA or just simple procedures?
Sorry, Dr. Mumbi, I didn't really get you there because my network was tripping a little bit.
Yes, so I was mentioning that I noticed that in the article, they have mentioned that the patients that they will admit a traditional way is these patients who are below the age of 1. yeah, they would admit these patients, but I think they didn't clarify. Any reason why you think maybe kids below this age, are there any special risk factors that we need to consider? Because this is important in terms of counseling the patient for theater, and that's how long are we going to keep them before and even after?
So usually, I think the kids that are usually under 1 are the ones that you'd find that they are more prone to like post-op apnea, and you sort of need to keep a very close eye on the patient. So I think they're probably just being very vigilant. And to also contribute to Dr. Ziambo's question on to say what, in terms of a protocol, what you actually have to do when you have an oculocardiac patient, and at what point are you going to be thinking, should I give atropine or not? So basically there are 2 things which you look at, one of which was mentioned in the article, to say, you start looking at, is my heart rate going 20%, has it got dropped by a 20% margin from the one that I had before? And then the second thing also is that when you're having your drop in your heart rate, you need to figure out how is it affecting the map, which was also mentioned. So you need to check your BPs frequently and make sure that your patient is at an acceptable map. If they are going down, then you need to start giving your atropine quickly. Okay.
Okay, thank you very much. I think, I'm not sure whether we still have any comments from members. Dr. Tuso, any comments you would want to make?
Thank you, Dr. Mumbi. For us, admissions in government hospital, we admit all children as long as they're going under GA, but that is in government hospital. It might be different in private hospitals. Every child that undergoes GA has to go through the pre-op and also post-op, they have to be monitored. And then we don't have severe cases of ocular cardiac reflex. We have never had an asystole. So we don't give atropine unless if it's required. Mostly the only thing that anesthetists will do is inform the surgeon to be more gentle, like to release pressure and all that. Thank you.
Yeah, thank you, Tuso. Any more comments, please, concerning the article also?
Can I make one comment on the article, like a critic?
Yes, then.
This is Dr. Nchimuni.
Yes.
Yeah, I don't know what you thought about the title. I think it wasn't concise. Looking at the title, you don't know what you're going into. But it's only when you start reading the article then that you realize that it's more specific to strabismus surgeries, or to surgeries where you can get an ocular cardiac reflex. Maybe they should have made it a little bit more specific.
Yeah, not really. It's only that they found more oculocardial reflex and strabismus cases, and the reason why is because you are tagging on the particular case. But as Dr. Sampa mentioned, is any intraocular surgery, any surgery that you're going to do that is going to compressing on the. I think Dr. Patel, if you remember, I'm not sure whether it was with you. Last time when you had oculocardial reflex, Dr. Tembo, under local anesthesia, would you want to share that experience in an adult? I think Dr. Patel or Dr. Tembo, I can't remember exactly who had. I think you are with Dr. Kaswampe. Dr. Tembo?
Yeah, I didn't experience it, but I remember there was one adult, I think was undergoing cataract surgery. It was just reported in the eye clinic. And I've noticed that we had just had the presentation on oculocardiac reflex, and then people went for surgery, and then
Dr. Tembo, we can't hear you. I think we have lost Dr. Tembo. I think we have lost Dr. Tembo. Yes, Doc?
Are you able to hear me?
Yes, we can hear you now.
Okay. I was saying that it happened in an adult. So what the patient was given atropine, and then also I think anesthesia was called in. I think some
What procedure?
oxygen.
What procedure were you doing exactly, and what happened?
I wasn't the one doing the procedure, but I'm told it was cataract surgery that was being done.
Okay.
So I think it was the time where they were tugging on the superior rectus muscle, and the patient went in, experienced the oculocardiac reflex.
Yeah, thank you. So there isn't really, yeah, so there are no simple surgeries. Everything has a risk. These are some of the learning points that we get. And it's always recommended, yes, sorry about that. And it's always recommended that we need to be safe. So even procedures that we might consider as being simple. One of the things that we may invest in our centers is having a pulse oximeter and an oxygen tank on the side. So during my training, I was always wondering why it was like that. And then I noted that because it was a high volume center, we would see a number of these patients who would be dyspneic. You see saturation dropping, and patients would generally be complaining. And I think today also I had a patient who was having a pulse going somewhere around 40 or so, you know. So also all those things, when you have the basic things that are available, be able to identify the challenges early and call for help. So I think one of the recommendations, even under the learning points that we get, even under local surgeries that we get, is that let's ensure that we have on the side even just a basic pulse oximeter, patient connected. And since we are covering the patient's faces, let's see if we can have an oxygen cylinder with nasal prongs. Okay, we have done exactly 1 hour from the time we started, and that was the time that was allotted. Unless there's any burning points that colleagues want to make, either generally on the anesthesia concerning the ophthalmology, generalizing it, or the specific article. The presenters also may come in. I'm sure during your stage, you are the authorities on this. You must have learned a lot, and the number of things that you see being done that you thought were correct, were actually wrong. Yeah. So yes, please proceed.
I think what we have learned from this article, and just to comment generally, is that when we're doing operations, especially in children, like you said, rightly said, we should always have an anesthesiologist on standby. Also, an important factor is the pre-op preparation for these kids, and also the post-op management of conditions. In our setting, sometimes we don't prepare our patients adequately. You know, where a child comes into theater, frightened, crying, and all that, and then the child is put under general anesthetic. So when the child wakes up post-operatively, they are still frightened, and that psychologically, it impacts on them even for long term after the surgery has happened. So preparation pre-operatively is very, very important. And also pain management is very important. Then on the article, the analysis, how they were scoring these things, like, you know, post-op, these scales, the validation scales. The first one was the face, leg, activity, cry, and consolation. You know, how did they do that? Was it one person doing that observation, or there were a group of them? Because these can lead to bias. Depending on what you see, you can record it as normal or not. So some of those, they didn't clarify exactly how they were doing that. On the scoring of pain as well, they said 2 is the facial legs activity crying score plus VAS, and these are not very clear. How did they come to that? Because it can be very biased, only one person observing, and it can look normal to them, but to others it cannot. So it was a little bit vague. I hope they could have clarified it much more than what they did in the paper. Thank you. The presentations were fantastic, ladies, doctors. Keep it up.
Thank you so much, Dr. Paula.
Thank you very much. Thank you.
Yes, Dr. Paula, the points that you have raised are really valid. And one of the things, the beauty about using the Marie way of pre-taking, it gives that guide. So even when you are doing your own research, you can use that as as a checklist to just ensure that how did you address the bias. This point clearly they have not raised it, because this issue of biasness is going to tell whether we should believe this study and whether we should be able to apply it. I just want to mention that the whole point of doing a journal club is to see how, we need to learn a number of things, how we need to make scientific decisions, evidence-based, without attaching emotions, because most of us say or do something based on what we have seen or what we feel is the correct way. But remember that everything must put into context. And this training is helping us either as practicing physicians or as physicians in training. So this journal club, I just want to re-emphasize that is something that we should take with utmost importance, of which I've seen looking at the attendance and also the participation. So I'd like to thank you everyone who has taken time off. It's not easy to leave your busy schedules and come and listen to something that sometimes you might think you'll be wasting time. But all this is done for the benefit of our patients. Okay, any comments as we close? Dr. Mupansha, any closing comments? And I've seen Dr. Ebo Male. Dr. Ebo Male, could you make any final comments as we close? I think he has left. Okay. Dr. Mupansha?
Thanks, Willard. Maybe I will leave it to Dr. Msadabwe to make some final closing comments on the presentation and the article.
Thank you. Yes. Yes, Dr. Nchimunya, you conclude, because most of the time you are the one who is seeing these our patients. So after your conclusion, and then we close, I'll just make one announcement.
Okay, thank you very much, Willard. I think just to conclude, as we all know, oculocardiac reflex is something that can happen with any ophthalmic case. So it doesn't really matter whether it's a small case. And I think even in my experience, I've had more patients who I've had to treat oculocardiac reflex mostly in cases like exenterations and the cataract cases. And so, and these are quite the common cases that we have. So I think one thing that we need to take home is that whenever you're dealing with the eye, because remember, it's even just a bit of traction that can cause the reflex. So these are things that we should always look at. So that is why it's important, as you mentioned earlier, to say, even when you're just doing a cataract, you should have a pulse oximeter on the patient just to monitor and see how things are going. I think that's where I'll end.
Okay, thank you very much, everyone, for your attendance. We gave a few colleagues to make summaries. We had given Dr. Mebo and Dr. Ahmed, and I think Dr. Tembo, if I remember well. We don't have time, but what I would advise is whatever points that you have compiled, you can forward them to me. I'll forward some to Dr. Mupansha, and perhaps Hazel, what we might need to do, I don't know how this is feasible, like Dr. Funjika has mentioned, is that we might need to come up with the protocols I mean, like just specifically to help us, something that someone can fall back to, putting in place our costs locally here. So some of these things we can afford, but others we might not be able to afford. Okay, so our next presentation will be next week Thursday. This will be done by the team from Kitwe to do with nasolacrimal duct obstruction, and then the other week is something interesting also on microbiome disease. Okay, so we close, and thank you everyone for your participation as we continue learning.
Thank you.
Thank you.
Thank you.
Thank you so much, all. Good presentation.
Thanks. So